All right, let's talk about the cardiac system. When it comes to the cardiac system, we'll be talking more about the heart. Pay attention to this because definitely you'll mess up with these questions or you're in trouble as far as NCLEX is concerned. Priority concept that I'm going to talk about is going to be health promotion. This is where you'll be teaching your patients lifestyle changes to prevent complications of failure. You'll also be talking more about perfusion. That's the transport of oxygen to all parts of the body or to all tissues that needs them. So mostly all the conditions I'm going to be talking about are going to be problems with getting oxygen. So we're talking about problem getting oxygen to the heart, problem getting oxygen to the legs, problem of getting oxygen to the lungs. These are the ones that we're going to be talking about. So perfusion, as we rightly define, is just the transport of oxygen from the lungs by the blood, all parts of the body that needs them. So let's look at the first diagnostic tests or procedures that we're going to be talking about as far as NCLEX is concerned. Our labs values that you need to be more concerned as far as the cardiac system is concerned is number one, troponin. Anytime you hear troponin, please think about myocardial infarction. Troponin is the best indicator of telling us that we have MI. Now, when it comes to creatine kinase is also related to myocardial infarction. But if we have other muscles that are also impaired, that creatine kinase will also be released. So it is not that cardiac specific, but an elevated of the creatine kinase is also an indication that yes, we have an injury to the heart, and that's myocardial infarction. But it is not always absolute that yes, when my creatine kinase goes up, it's not always true that it is the heart. But then the troponin will be the best indicator that we have muscles damage. Next is going to be complete blood count, which is called CBC. Usually, when we are concerned about infection, we want to know the white blood cells that is going on. We talk about the CBC. The doctor will order for that. Now, when the CBC comes, we'll be looking at when CBC, when the white blood cells goes up. Usually, the first thing that comes in mind is that we have infection. This time round, as you prepare for the NCLEX, it is not always infection. If the person also have myocardial infarction, then the white blood cells can also go up as well. So why will the white blood cells goes up when somebody have myocardial infarction? The reason is very simple. These white blood cells are responsible for disposing the necrotic tissues or the dead cells from the blood. And so when myocardial infarction occurs, some few days following myocardial infarction, the white blood cells will go up. And the question is, how do you know if it is myocardial infarction and not an infection? Usually, in the case of myocardial infarction, look for the temperature. If it means the same and there's no increase in temperatures, then definitely is going to be myocardial infarction. On the other hand, when the temperature begins to go up and the white blood cells goes up, that is an infection. I hope that is clear. The other ones we're going to talk about is called hematocrit. Hematocrit, we're talking about the solid portion of the blood. In this case, whenever the person is, when hematocrit get elevated, the sign that the person has, it's likely the person is dehydrated. So think about you having salt being dissolved in water. When you evaporate the water, what happens? The salt concentration increases. And sometimes it get to a point that we have the salt will begin to crystallize. The same thing, we're talking about hematocrit, which is the solid part of the blood. So when your volume, the volume of blood goes down, then definitely the hematocrit will go up. That is what you need to know about hematocrit. On the other hand, When hematocrit levels drops, then it means that we have fluid overload. We have too much water in the system. Either the person is retaining fluids in the case of a heart failure. That is all hematocrit is telling you. Now, other thing that you can also talk about is going to be the red blood cells. The red blood cells, these are the ones that are responsible for um, carrying oxygen to all parts of the body. And so when there's a decrease in the red blood cells, in the case of rheumatic heart disease or infective endocarditis, the person's oxygen capacity or carrying capacity will go down. So as a result of that, this patient will be more fatigued easily. So these are the things that you need to know about the red blood cells. These are the ones that are responsible for carrying the oxygen. A decrease in red blood cells will result in low oxygen carrying capacity or inadequate um, tissue perfusion or inadequate, yes, let me put it that way. We have an inadequate tissues oxygenation or perfusion. Let's go to the next slide. On the other hand, when we have hemoglobin levels which are going down, and we have hematocrit levels at the same time going down, this is a sign that this person is anemic. So take note of that. So when you see your lab values where hematocrit levels are going down, and then the hemoglobin levels are going down, which also carries the oxygen, then definitely what is happening is that we have some kind of anemia going on. Either the person is bleeding, and usually the doctor will say that let's transfuse some blood. There are different kind of anemia, which we're going to be talking about that. So on the unit, when you get in a report and then you hear the word H and H, the person H and H is down, that means that the person is anemic. So hemoglobin and hematocrit, that's why we call it H and H. Please take note of that. Usually when H and H goes down to a certain point, our best intervention will be that transfusion. Let's come to coagulation factors. You will hear this word a lot. With coagulation factors, we are referring to the ability of the blood to clot. And normally, these coagulation factors are released when we have an infraction. And so, when somebody gets an MI, our main concern is that this person is likely to get a blood clot because the clotting factors are going to be released. So, an increase in coagulation factors, which are the clotting factors, can occur during MI. This places the client at risk of blood clot formation in the coronary artery. And that is the more reason why whenever somebody gets MI, where we suspect that there is an injury to the heart muscles, and then the probability that there will be a blood clot, it can dislodge itself and go to the brain and cause stroke. The doctor will prevent this clot formation by putting the person on anticoagulant. So anticoagulants are going to prevent the blood from clotting. That's all that you need to know about blood coagulation factors. So without these factors too, it means that when the person is bleeding, they cannot stop the blood, or the bleeding will not. Sorry, when the person is bleeding, the bleeding will not stop. So yes, we need these clotting factors. But when somebody get an injury, it also put them at risk of getting the blood clot, which can go into the brain and cause stroke. It can go into the lungs and cause pulmonary infraction, which is PE. Oh, sorry, yeah, pulmonary infraction, or it can also cause pulmonary embolism when the clot finds itself in the pulmonary arteries. All right, let's come to the next lab value, which is also very important when it comes to the cardiac. That is the lipid levels. Most of the cardiac problems that we are going to have or we're going to talk about is related to cholesterol. When cholesterol is building up in the blood vessels, it is what we call atherosclerosis. In this case, it prevents the free flow of blood to all parts of the body, including the heart, also the lungs. especially with the heart. So, since we are talking about the cardiovascular disorders, most of the problems that are going to face originate from the deposit of lipids in the blood vessels, especially in the coronary arteries, and that will cause the coronary artery disease. In this case, blood will find it difficult to flow to the heart muscles for perfusion. And therefore, if this is what is being suspected, the doctor will put the person on low cholesterol lowering medication. The most common one is Lipitor, or we'll be talking about the statins when we come to the cardiac medications. So basically, this is what you need to know when it comes to the CBC. All these things will be found when the doctor ordered the CBC. Now let's come to the next level, which is called electrolytes. As far as the heart is concerned, the most tested electrolyte which has an effect on the heart is going to be potassium. When potassium levels are low, we call it hypokalemia. And when potassium levels are high, we call it hyperkalemia. There's one thing you need to know, whether low or high, the main reason why we are all afraid of potassium is that they cause ventricular problems or ventricular dysrhythmias. If it's low, it causes ventricular dysrhythmias. And if it is high, it also causes uh, the same ventricular dysrhythmias. But in the case of hypokalemia, it's one thing I want you to be aware of. They like they like testing you on digoxin. Digoxin is usually used for heart failure, which increases the force of contraction, which I'm going to talk about when we come to heart failure. But I want to mention it here because it's one of the most tested cardiac medication. All it does is that it increases the force of contraction of the heart. And anytime you're going to give digoxin, one of the things you have to do is to get the epical pulse or check the person's pulse for 1 full minute before you give it. If the pulse is less than 60, you need to notify the provider before you give it. On the other hand, when potassium levels are low, it causes the digoxin levels to go up. Digoxin has a very low therapeutic range, and therefore, anything that will cause digoxin levels to go up will cause toxicity. And one of the electrolytes that causes this to happen is the potassium, especially when the potassium levels are low. So please take note of that. In hypokalemia, the EKG will always shows that we have a T wave inversion. This is something that I'm bringing out. It's not the most tested one. But one thing you need to know is that if it's hypo, everything on the EKG is low. So we have T wave that will be inverted. We also have the U wave that will looks like U is also low. And the only time you see the U wave is when you have hypokalemia. Then ST segment will be depressed. And remember, when we talk about myocardial infarction, when we use an EKG to determine if a patient has a cardiac problems, we focus on the ST segment. When the ST get elevated, we say that the person has ST elevation myocardial infarction. And remember, the only thing that determines whether we have myocardial infarction is the lab value troponin. So when the troponin level comes and it is high, when the ST segment is elevated, we say that that kind of myocardial infarction is ST um, elevation MI. On the other hand, when the troponin levels comes out and it is still high, even though the ST segment will not be elevated, we still will call it myocardial infarction. But this time around, we call it so which is NSTEMI, non-ST elevation MI. So when it comes to potassium, please think about the heart. Whether low or high, this is what we have. We are going to have a ventricular problems. And whenever the ventricles pumps, when we come to the cardiac, the pumping ability of the heart, Anytime you have a cardiac problems, a ventricular problems, then we have problem with oxygenation, and these are either life-threatening or they are lethal. So, for example, I'll be talking about VTAC, where the ventricles are contracting at a faster rate. In this case, if care is not taken and we convert it back, we might lose the patient. On the other hand, when the ventricles are fibrillating, which is called VFib, this is a life-threatening situation. You need to defib the person right away. If not, within the next 5 minutes, 3 to 5 minutes, we're losing our patient. Then I talk about VTAC. This is where the ventricles are um, contracting at a very higher rate. So whenever we have a ventricular problems, that is either a medical emergency or a life-threatening situation. Now, in hyperkalemia, what happens is that in the EKG, everything is high. So in hyperkalemia, it will show peak T wave, the QRS will be widened, and then the PR interval will be widened or will be prolonged. And sometimes you have a flat P wave. You might not see the P wave at all. Now, there's one thing I want you to understand. When we have these potassium levels going up and then either going up or low, we want to prevent the ventricular dysrhythmias. And how do we prevent that? We want to make sure that we have the medication called calcium gluconate. It has to be at bedside. Usually, we give calcium gluconate to prevent this ventricular dysrhythmias. But one thing I want you to know is that this calcium gluconate will not fix either the hypokalemia or the hyperkalemia. It's just there to prevent the complications of the hyperkalemia or the hypokalemia. Let's come to our next electrolyte. It's called sodium. With sodium, please think about the neurologic, which is the brain. Usually, with sodium levels being up or low, the person will have altered mentation. So we have altered mental status. So let's look at what will cause sodium to be low or high. In case of sodium, when we start using diuretics, which means the medication that help us pee a lot, it will cause the serum levels of potassium, or it's going to change the sodium levels. And again, if we are also having a heart failure where we begin to retain fluid, it will also change the person's sodium levels. So whichever way, whether up or low, it is not good for the brain or the neurovascular system. So when it comes to sodium, think about the augmentation. But when it comes to potassium, think about the heart. Next week, I'm going to talk about is going to be calcium. Calcium levels are also very important for us to monitor. As far as the heart is concerned, calcium will also cause ventricular dysrhythmias. With calcium, you have prolonged ST and then QT intervals. And when calcium levels get so low, it can also cause cardiac arrest because calcium is one of the electrolytes that affects the contraction and relaxation of the muscles. The heart is full of muscles, so calcium has a very big effect on that. Let's look at the next. When calcium levels are high, that is what we call hyperkalemia. And with hyperkalemia, this can also cause the same um, ventricular problems. So again, but with hyperkalemia, it causes everything to go down. So in this case, this can cause shortened ST segment, and then it widen the T wave. Then we talk about atrioventricular blocks. So hyperkalemia can cause the heart blocks. So think about that. Then you can have tachycardia or bradycardia, depending on what is going on. Then it also increases reducing activities as well. And if it is too high, we can get a cardiac arrest. So calcium levels are not also good for the heart when they go up or low. Next, that also affect the heart is magnesium. Low magnesium levels can cause ventricular um, tachycardia or ventricular fibrillation. So this again is another ventricular problem. So we have problems with oxygenation. This is not the atrium, it is the ventricles that are also involved. And that's why low magnesium levels it has to be treated with a matter of urgency. The electrocardiographic will changes that may indicate or may be observed when somebody's magnesium levels are low involve T wave and depressed ST segment. The high magnesium levels can cause muscle weakness. It will also cause hypertension and bradycardia. So when magnesium levels are high, they do the opposite. What they do is that instead of blood pressure to go up, blood pressure will drop, the heart rate will drop, and also the person will be weak. So take note of that. So magnesium is not something that we joke with as well. When it comes to the electrographical changes, we will be observing that when the person magnesium levels are high, we also prolong the PR interval and widen the QRS. Next, after I hope by now you know your electrolytes because you'll be tested on them. If you will not learn anything, please don't joke with potassium. Now, let's look at our next lab value. It is called BUN, which is called the blood urea nitrogen. Whenever we have a heart problem that results in having effect on the renal system or on the kidneys, I will usually refer to it as a renal system because the kidneys are just part of the renal system. So in this case, we have to be measuring the BUN, which is an indicator of a renal function. So BUN is called blood urea nitrogen. On the other hand, the best indicator for the renal function is going to be our creatinine. But I'll talk about them more into details when I start treating the renal system. Next is the blood glucose. Whenever somebody is having a cardiac episode, most of the time the blood glucose go up. So when somebody complains of chest pain and we feel like he's having the cardiac problems, we also will check the blood glucose. Now, when you check the blood glucose, you see that the blood glucose levels will go up. Let's talk about the next lab. We'll be talking about heart failure. The lab that indicates that we have a heart failure is called BMP. And this medication or this BMP is released usually when the ventricles are stretched and the atrium are stretched. That is where you see this lab value coming in. So in this case, always remember that when you have a BMP that is elevated, it's a sign that the ventricles are overstretched and then also the atrium is also overstretched. And when that happens, the pumping ability of the heart goes down. And that's why we say that this is the best indicator for a heart failure. Now let's come to the imaging. So we did talk about the labs. As far as the cardiovascular system is concerned, these are the labs that we need to know. You need to know your BUN. You also need to know your electrolytes. You also need to know that we have the CBC that can be drawn, so white blood cells. But at least you've learned that when the white blood cell levels are up, so there's you still have to go ahead and check the temperatures. We have elevated temperatures. If not, about myocardial infarction. But if they get um, elevated, think about more of infection. So please, when the exhibit are given to you, make sure you take note of that. Sometimes that piece of information can make a whole difference. Okay, with the imaging, we'll talk about chest X-ray. With X-ray, it shows us whether the heart is enlarged or not. But when you have an order for chest X-ray, please make sure you take every jewelry on the person body, and also ensure that the patient is not pregnant. So one of the things that you have to consider as a nurse when you have an X-ray order is that if it's a female patient that it has the potential of being pregnant, you want to make sure that you have a negative pregnancy test before you carry out the X-ray. But when the question says that the person is, let's say, 65 years old female, you know that they're not going to have babies. Neither would they say the person has a history of hysterectomy. So definitely, you know that the person doesn't have a womb. And in this situation, they will not be able, you don't have to worry about pregnancy. Now, let's look at electrocardiography. When we talk of electrocardiography, what we are saying is that we are looking at the electrical activity of the heart. And in this case, it's being represented in the graphical or in the graphical image. And that is what we see when we take the EKG. So this is a non-invasive diagnostic test, and it will record the electrical activities of the heart. These EKGs help us determine if we have any cardiac dysrhythmias going on, and then if we have any MI, and sometimes it even tells us the location. Then when we have cardiac hypertrophy, that's when the heart becomes enlarged. And for evaluation of effectiveness of medication, there are certain medications that we talked about, especially the psych medications. You notice that we have to get an EKG to see the QT intervals. And again, there are other medications that when you're giving them or when somebody is on certain medications, the stimulants, we have to be monitoring or we have to get an EKG just to make sure that the medication is not causing too much harm to the heart. Next imaging I'm going to talk about is going to be echocardiography. Anytime you hear echo, think about sound, which means that we're going to use sounds to determine if we have a cardiac problem. If we're going to use sound, it means that we have to think about the flow of blood. Again, it's a non-invasive procedure and is based on the principle of ultrasounds that evaluate the structural and functional changes in the heart. Now, it is used to determine if we have a valve problems. So when we have valve abnormalities, and then the blood is flowing through from one chamber to another chamber, either the valves are open and cannot close, or the valves are not opening, or they are narrow. So all these things will alter the way the blood will flow in, and it will be captured um, by the ultrasound. And so that is one of the best indicator for determining valvular abnormalities. Again, when a child is born and then they have any abnormalities in the heart, for example, when the ventricular septum is not closed, because there'll be another flow of blood in a different pathway, the the echo can pick it up. So you'll be hearing heart murmurs in questions. This is where echo pick it up. Then you'll be talking about ejection fraction, the amount of the amount of blood that is pumped when, or the fraction of air. Oh, sorry, why did I keep saying air? The fraction of the blood that is pumped out when um, during contractions. This is what we're talking about here. So let's look at this. So ejection fraction, and sometimes we can use it for cardiac functioning. It's one I want you to understand. It's called transesophageal echocardiography. So meaning that we're going through the esophagus to get the echo being done. And in this case, you have to make sure that because this is going into it's an invasive procedure, with this one you need an informed consent. Now, in which echocardiogram is done through esophagus to view the postural structures. This is an invasive and require preparation, preparation and care similar to endoscopy. So we need to get an informed consent for that. So what are some of the interventions? You all have to determine if the client has the ability to lie down for a little bit of time. So in this case, you advise the clients to lie still. You'll be breathing normally, and also refrain from any talking during the test. So that is all echo is all about. Now, there's another test I want you to ask to know. It is called exercise electrocardiography or stressing test. We hear the word stress. So, which means that this is a test that determines the electrical activities when we are under stress or when you are doing an activities. So, this is also another non-invasive studies that um, determines the heart activities when to evaluate the coronary artery if we have a coronary artery disease or not. So it is non-invasive. We want to see if we have a correct blood flow to the head or how is the heart responding with respect to activities. Usually we use a treadmill. The patient will be on a treadmill and then they will have a transducer on the person, and then whatever they are on a treadmill exercising, the electrical activities will be recorded, and then the doctor will come and figure out if we have if it is normal or abnormal. If the client is not, so when the client is a treadmill, the client doesn't need to be MPO, and again this becomes non-invasive, so we don't need an informed consent sign. But on the other hand, when the client is not able to tolerate any exercise, then the provider might opt to give what we call an intravenous infusion of dipyridamole or this medication. We call it du- dibutamin hydrochloride. And this will help dilate the coronary arteries and stimulate the effect of the exercise. So in this case, the doctor is the one that is inducing the exercise or the stress on the heart. So the client in this case will have to be NPO and then at least 3 to 4 hours. But what you need to know is that if they decide to go the IV route, then definitely you have to put the person on NPO. That is nothing by mouth. So let's see if a person get a stress test order pre-procedure. Before the patient will go, make sure you have an informed consent signed if it requires an IV infusion. If not, encourage a client to rest the night before the procedure. Why? Because we are going to put stress on the heart, but we want to do it as normal. If you don't sleep enough, it's going to affect the results because your heart will begin to be pumping faster than normal. Just imagine you did not sleep the whole day. What do you notice when you wake up? You even feel tired. You want to instruct the client with a non-invasive test to eat for them. If it is non-invasive, they can eat a meal that's 1 to 2 hours before the procedure. That is allowed. But if it is going to be IV, then that is not allowed. They have to be NPO. You want to instruct your client to avoid smoking. Why? Because smoking will constrict the blood vessels and that will alter the results for us because when that happens, it puts too much pressure on the heart. Alcohol, the same thing, is a downer. We talked a lot about alcohol. It's a downer. So again, make sure that you let the provider know or you have to question that if the person is an alcoholic. Next, we're going to talk about caffeine. Caffeine, please, there's a difference between coffee and caffeine. Caffeine is the active ingredient, is the stimulant that is found in coffee. The same caffeine can be found in tea. The same caffeine can be found in other drinks. So caffeine and coffee are not the same. Let's look at post-operative interventions. They come back. You want to instruct your client to avoid taking a hot bath or shower for the first 1 to 2 hours. Why? Because the blood vessels have already dilated. Taking a hot shower will further dilate the blood vessels, and that can cause syncope. Let's look at our next imaging. It is called MRI. It's magnetic resonance imaging, MRI. So when we talk of MRI, we are looking at the following. MRI, we looking make sure that this is also another non-invasive test. Again, we don't need an informed consent. But with MRI, please, before the patient will go, make sure that they don't have any pacemakers. And also remove all metallic objects. If they have any hidden metallic object, the MRI machine will bring it out from the person's body. Don't forget about what happened in New York, I think recently. So the visitor that went into the MRI room and then got killed because they had metallic stuff in their body. Now, you need to get an informed consent when you have when inform the client. You don't need an informed consent for this. If the client is claustrophobic, this is where we try as much as possible to calm the patient down, and usually we use some of these benzos to help them calm down. Again, the kind of benzos that will be used is going to be the provider's preference, our um, not that one is not within our scope of practice. The next cardiac procedure I'm going to talk about is cardiac catheterization. When we talk of cardiac catheterization, this is an invasive test. And this is where a catheter will be inserted into one of the major arteries, and it is used to evaluate any structural changes or when there is anything that is preventing circulation within especially the coronary arteries. So let me read what is here. It said that it's an invasive test that involves insertion of a catheter into the heart and the surrounding vessels, obtain information about the structure and performance of the heart chamber and valves and the coronary circulation. So when you see the person is going for a cath lab, this is what we're talking about. You're going to insert a catheter into the patient's uh, coronary arteries, that is the blood vessels that supply the heart with oxygenated blood. You are the nurse. How will you prepare this patient for this procedure? You make sure that they have an informed consent signed. Then the next one is you assess for allergies to seafood. Remember, they are going to use a contrast dye, and therefore anything that any reaction the person had with the dye, it needs to be investigated. Next, you also have to make sure that this patient is MPO. They have to they will not eat for at least 6 to 8 hours. But again, I'm not going to talk about the duration. Know that they are going to be NPO. This is to prevent vomiting and aspiration during the procedure. Don't forget that document the client's height and weight. The reason we want to document the weight is that, and height and weight is that most of the time, the amount of dye that will be injected in the person is being determined by the client's BMI. So that's why we need to get the height and the weight. Very, very important. Now, you also want to document the baseline vitals before the procedure, and then when they come back, you have to be monitoring their vital signs as well. The insertion site when they come when the insertion site will provide the team will tell you where they want to go. Either they want to go in Greeno or they want to go the brachial or they want to go the radial. Wherever they want to go, they will let you know. Your job is to make sure that the place is shaved, clean with antiseptic solution. So that's all that you need to know when it comes to the cardiac lab. I'll talk about the cardiac lab later when we start talking about the disease process. I can take somebody to the cardiac lab. Now, if a client is taking metformin and they're going for any of the dye procedure, please, 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 you need to hold the metformin at least within 24 hours prior to the procedure because this client will now be risking getting what we call lactic acidosis. We did mention this again when we were dealing with the renal system. You need to make sure that their kidneys are working, and at the same time, if it's a dye procedure, metformin has to be held. This medication is not assumed on. It's not. You don't resume it until the healthcare provider ordered it to be resumed. Usually, after 48 hours, the provider will resume it, but it's up to the provider to decide. This is our reason or our problem. So let's look at some of the post procedures. Procedures that we have to follow or post procedure when they come back. Now, when they come back from the cath lab, remember they just came back from the lab, and therefore bleeding is number one thing that we are going to be assessing. So we're also going to be monitoring their pulses. That's what I call the neurovascular assessment. So you'll be looking at the site where the catheter was inserted, and what you are going to be looking for is numbness. You'll also be looking for bleeding. You'll be looking for any sign of loss of sensation. Those are the things that you should be looking for. So you monitor the peripheral pulses and color, warmth, and so if there's a change in color, like um, from pink to pale, it's a sign that we have less amount of blood going to that side, which is a perfusion problem. So if they are also cold, it also tells you that um, we have oxygenated blood, which contains nutrient and oxygen, is also being cut off from that side. So we have another circulation problem. Then we also have sensation of the extremity distal to the insertion site. Also have to be monitored every 30 minutes for the next 2 hours. So you have to be, because we have to be more focused on bleeding precautions. Remember, they went into an artery, not a vein. So you need to be more careful. You want to notify the healthcare provider if any complications of numbness and tingling happens. If the extremity becomes cold, pale, cyanotic, or if loss of peripheral um, pulses occurs. This indicate that there is a clot somewhere and it needs to be assessed immediately. Immediately. Now you want to apply a sandbag or compression device to the site to provide additional pressure if needed. So our main concern is bleeding when they come back. You want to monitor for bleeding. If bleeding occurs, apply manual pressure immediately and notify the healthcare provider. Monitor for hematoma, and then also if the hematoma develop, you have to notify the healthcare provider right away. Then you want to keep the extremity extended for at least 4 to 6 hours as prescribed, keeping the leg straight to prevent arterial occlusion. This is very, very important. I've seen questions where uh, people were elevating the legs. You don't. You are going to be what? You keep the extremity extended for 4 to 6 hours before you start to even bend it. If you bend it too much, you are going to cause another bleeding. However, clients may turn from one side to another, so mostly they can turn, but they will not be walking to the bathroom. Do not elevate the head of the bed more than 15 degrees. This is also very important when they come back from the cath lab, especially when they use the in the inguinal area. Because once you elevate it more than 15 degrees, they risk occluding the artery that was used for the procedure. Now, you want to encourage fluid intake because of the dye when they come back, because the dye needs to be peed out of the system, and that is one of the things you need to know in the renal portion. So in this case, anything that is contraindicated or contaminated, it needs to get out. Now, if the anticubital vessels are used, immobilize the arm with an arm board, and I'll show you one when we meet in class. You want to monitor for nausea, vomiting, rash, or any signs of hypersensitivity to the heart. The heart. This is how it looks like when somebody goes to the cardiac lab. Usually, they either go through the inguinal area here, or they can also go up here to go into the heart, and then study the activities that is going on in the heart. I hope by now you've gotten